just to sum up here in terms of symptoms or signs, so the diagnosis of IIH can still be made if the patient is completely asymptomatic, but they have papilledema. And in fact, many of our patients we see in our clinic are sent by local optometrists or ophthalmologists, people who just went for a regular eye exam. They just went to get their glasses updated. And the doctor saw, oh my goodness, the nerve is swollen, and the patient was referred over, and they had no symptoms whatsoever. So they're completely asymptomatic, but they had incidental optic nerve edema on exam. And then we do the workup, and in many cases, it ends up being IIH. So that's one scenario. But the other scenario can also happen where, again, the patient is symptomatic, but they do not have papilledema on their exam. Also as part of the criteria, the updated criteria, no other cause of intracranial hypertension should be identified. And there is a very long list. This is not even the complete list, but we look for, or we ask about all of these conditions. We ask about medications. Have they taken recent antibiotics? Are they on a vitamin A derivative for acne? Do they take vitamin A supplements? Have they recently been on steroids? Could there be steroid withdrawal? Are they on any kind of psychotherapeutic agent like lithium can cause raised intracranial pressure? Growth hormone can cause increased intracranial pressure. And then there's some medical conditions as well. And the two I'll point out that I think are the most important to really rule out include sleep apnea. Sleep apnea can be associated with raised intracranial pressure, IIH, or actually it would be not IIH, but pseudotumor cerebri syndrome. And also iron deficiency anemia can also be associated with raised intracranial pressure. So then the final criteria is the neuroimaging. So we need to make sure that there's no hydrocephalus, mass, structural, vascular lesions. So what type of imaging is really best? Well, ideally, we like to get MRIs of the brain with and without contrast. If MRI is not readily available, let's say, the machine is down, or, a patient is in a rural area, they don't have access to an MRI right away, at least get a CT. And preferably a contrast-enhanced CT if the patient is atypical. If they're younger, if they're older, if they're male, if they're not overweight, if they're not obese, get that contrast-enhanced CT. And then also for atypical patients, we do routinely do MRVs. And we've actually been moving towards doing MRVs on just about everyone with IIH, because we do want to know what their venous anatomy looks like, and can help guide us in some cases.